Okay, welcome to Spine Conference. Today's discussion will be spondylolisthesis, which is a common topic. And so it's a 50-year-old woman with left sciatica. The pain, she's had the pain for 6 weeks. Grant's going to be the presenter. 6 weeks. Pain radiates from, you ask her to point with one finger. She takes her one finger and she points to her lower back, left buttock, left posterior lateral thigh, left lateral malleolus. Is there anything in your head right now when people point to their left lateral malleolus? I usually think L5, but it could be S1. S1 usually.
That's right.
It's okay. I mean, it could be S1. I mean, what do you think, Paul? Like with experience.
L5.
L5. Lateral malleolus is at L5. S1 is usually lateral border of the foot. Okay. 6 weeks. So, and everybody gets an X-ray when they go to orthopedics. What do you see in the X-ray?
We got a apenilateral lumbar spine, no 3 fractures, dislocations. Disc heights, I would say, is reduced to L5, S1.
Okay. So
I think the other levels are pretty well preserved.
Okay. Okay, that's good. We have a lot to cover. So, flexion extensions. Sorry to cut you off.
Flexion extension. So, I do not see.
But it's not a trick question. It's not a trick question. Yeah. So.
How do you define dynamic instability since you brought it up?
So I would say I don't know if this is the correct way, but I like to look at the posterior aspect of the vertebral bodies and to make sure that there's no step off in between with both either flexion or extension compared to just the standing lateral. That's how I look for it.
So that's a listhesis.
Yes.
You said dynamic. I know.
Well, I mean like instability with flexion extension.
How do you measure that, and what would define dynamic instability?
I guess I'm confused.
So, I mean, you can look at translation of that vertebral body.
And how much translation do you look for?
I think,
Let's say it moves a millimeter.
yeah, I think it's more than that. I think when we talked about it once a couple weeks ago, you mentioned like 3. Was it 3?
3 millimeters.
Yeah.
Okay, so you can have a slit that doesn't move, and that's not dynamically unstable.
Okay.
So you document that as a listhesis. But if there's translation of 3 millimeters, then that is unstable.
Okay, so what would you, 6 weeks in your office? She never had an MRI. Who's the presenter? Who was it? Grant? What do you do for her?
6 weeks. Never had MRI.
Yeah.
And what's she?
No treatments. She has no treatment so far. What would you do?
If it's persistent after 6 weeks, I'll get MRI.
Okay, would you give her try anti-inflammatories, physical therapy? Is that in your wheelhouse? Steroids, pain pills, muscle relaxers, or no?
I would do a microdose pack probably.
Okay.
And then send a PT to get the MRI at the same time.
Okay. I mean, I'll do something similar. I mean, I mean, when you practice, it's an art. So I usually, if it's the pain severe, I give people steroids. If it's mild, I just give them meloxicam for 6 weeks, maybe a muscle relaxer. Would you do anything different, Paul?
No, I mean, if there's no neurologic deficit, I would be conservative. If there was a weakness, then I would get an MRI at 2 weeks.
Okay. So here's the MRI. What are your thoughts? We'll move to Ocean.
Sure. So we have, looks like he wants to do sagittals.
We have a lot of ground to cover, so none of these are trick questions.
Disc bulge at L5, L4.
Yeah.
Sorry, L5, S1, and then also a little one at L4, L5.
Yeah.
They're,
Disc height,
looks like they're probably a little reduced at L5.
spondylolisthesis.
Yeah.
No, none. Okay.
BMI of 43.
Look at this is important for me. Let's see this. So this tells you the surgery is going to be challenging, right?
Yeah.
Because this body habitus, she's 5'1", 200 pounds, but this body habitus right where you're going to do the operation is deep. And how does that make it difficult? Why does a deep wound make things difficult and a deep fat layer?
And really feeling worried about fat necrosis when you're retracting on all that.
Seromas, operative times longer. The other thing is like it's a long lever arm. So why is a hole hard? It's a really long lever arm. So all of your instruments has a lot of. It's difficult to control.
Yeah.
It's kind of like taking a flagpole and trying to like hit an object with a flagpole. So technically it makes it very difficult. But the benefit is the microscope has helped a lot with that, but not completely. Okay, so here are your axial cuts. So on the left is sacrum, and we're going to go like reading like a page, going across.
So there's enough, it looks like on the top left there's enough CSF fluid, no real central canal size for compression. It's a little tighter as you move to the right. You can see that little bit of a disc bulge causing some central stenosis.
Yeah, where could her S? I'm just moving quickly. I'm sorry to interrupt you, but
Sure.
where could the L5 nerve root? We said L5 nerve root.
Right.
Where could the L5 nerve root be compressed? Where?
So L5 nerve root can be compressed and a lateral recess at L4, L5.
Yep. Stop. So not a lot, but hold on, left right here. Not a lot, but maybe that's the L5 root. So
Right.
possibly.
And then
The facets are somewhat hypertrophic. And the other area?
and under the pedicle L5, so that nerve foramen.
Yeah, and also in the foramen, it could be in the foramen, right?
Right.
And the foramen of L5S1, the offender is this thing right here, the sacral facet.
Yeah.
So she definitely has L5 radiculopathy. Findings on the MRI, or how would you describe them? Mild, moderate, severe, like obvious?
Moderate, I guess.
Moderate, subtle. So what surgery do you want to do for her? She's failed all the medication 6 weeks, L5 sciatica.
Probably just, you said it's the left side?
Yes.
So like a left laminectomy.
Okay, decompression, no fusion.
She didn't really have instability. She
Okay.
wasn't complaining a lot of back pain.
Okay.
Things. You need to-
Test question's never a fusion unless it's obvious. Okay, decompression, which levels?
L5S1.
L5S1 and maybe L4, L5. Remember you
Depending on
said,
what her lateral recess looks like.
well, if you're either going to do it, you're not going to do it. So,
Do it.
okay. So that's what I did, L4, L5, L5S1, and I did a hemilaminectomy so that I could be sure the 5 roots fully decompressed into the foramen. You could see it very, very well. And she did great. Okay? You may not believe me, but she did. She did great. And the findings were mild. Okay, now she comes back 6 years later, and she says, Doc, it's back. So we'll go to Brett. What do the x-rays show?
Sure. So you see an AP and lateral, and it looks like there's some spondylolisthesis between 4 and 5. 4 is anterior to 5.
5-1?
25%.
How about 5-1 disc?
5-1, maybe a little less than 25%.
Lumbar lordosis, good, bad?
Probably increase a little bit.
Kyphosis, any kyphosis at any level?
Not that I can see.
Okay. Flexion extension views,
Can you
do
go
they?
back one, Spiro?
Yeah.
Quick and dirty method of evaluating that. If you look at the superior plate of L4, is it parallel to the ground, or is it slanting down or slanting up?
It is slanting down.
Down a little bit, so it should be parallel to the ground.
Okay.
Just kind of, if you want to just eyeball something without doing all the measurements, the top of L4, you want to be horizontal
Got it.
and parallel to the ground.
Her sacral, or her pelvic tilt is 67. I know because I did this whole conference yesterday and I lost it. Pelvic incidence, yeah, is incidence 67. I did, yeah. So, and the lumbar lordosis is maybe not 67, but yeah. And flexion extension views, what do you think, Brett? Obvious motion at 4-5 or any other level? Doesn't it look less?
Less. Yeah.
Why would the spondylolisthesis be less on flexion extension? I don't know the answer. Anybody know? Ocean's smart. Ocean, why would it be worse standing than flexion extension? Ocean
Would
can
the thesis be worse standing than
Yeah.
flexion extension?
Yeah. Why?
You'd be worse on one and reduce on the other, wouldn't you?
Yeah. Yeah, it's opposite, right?
Yeah.
Why? Yeah, it's like a theory.
Depends how the flexion extension were done. Were they done standing? Were they done supine? I mean, depends how you do your flexion
Supine.
extension.
Supine on the table, lateral
So
view.
gravity versus standing up versus flexion extension when you're supine, there's less different forces on the spine.
Maybe was it maximal flexion extension? Maybe she had a spasm. Maybe she had a spasm where it reduced with the spasm on flexion extension. Maybe she, I don't know. I don't know the answer. Okay. So MRI, we keep moving. Ocean,
So again,
4-5.
actually looks pretty well decompressed there at 4-5.
4-5 doesn't look as bad. Why? Why does the spondylolisthesis look better on the MRI?
She's laying down.
supine,
Yeah.
right? And it reduces,
Yeah,
which tells you what?
but there probably is some instability there.
Dynamic component, right? And why is this bright here? What is this brightness, and why is it bright?
The inferior articulating process of L4.
What joint is this thing?
The L4-5 facet.
Right. Why is it bright in the middle?
Could be cystic. Could
No, it's not cystic.
Maybe
You're. What happened? What did you just tell me?
fracture,
No. What did you just tell me on the MRI? Why is it reduced now?
because there's instability there.
Yeah. So what happened to the top part of her spine? Went which direction in the scanner?
Posterior.
Posterior. Right. Okay. So this whole port from here up, her whole body went backwards.
Yeah.
So why is there bright here?
Yeah, so like Grant said, there could just be diastasis
Yeah. Exactly. That's what I think. And there's fluid there.
there. Yep.
So whenever you see these bright things on the facet, what are you going to think in your mind? Maybe this is blank. When you see very bright fluid in a facet joint now, from now on in the MRI scan, you're going to think to yourself, maybe this is blank.
Stability?
Yeah, dynamic instability, right? Okay. So
if you do it in the reverse, you get this MRI, your next step is flex X. And you look at this MRI and you don't post this person for decompression.
Right.
Okay, so L5S1
There's a recurrent herniation there.
right here, this focal thing right here.
Right. Causing sternal stenosis.
How about this thing? What is this?
Hypertrophy, maybe an osteophyte.
Yeah, maybe an ossified major cerebral hypertrophy. L5S1 it would be compressing what?
Alpha, that's one that's lateral recess, so that's like that'd be right side L5.
S1 nerve root, right?
S1, yes, sir.
And 4-5? What's this stuff here? Is it a cyst like you said?
Maybe that's more the diastasis we're seeing again.
Yeah, the dynamic spondylolisthesis diastasis, right, within the facet. Okay, so how would you treat this? And 3-4, just so you guys know what normal is. So how would you treat this, Grant? Surgery immediately? She's really happy with you.
Repeat is she miserable with it or no?
Not too bad. First time in your office.
Yeah, back
You're
pain now.
back in left sciatica. You're a doctor now. You're like in practice. She likes you. She said, "What do I do, doc?" Because she trusts you.
I would send her I would try PT, oral, analgesia first, and then if that fails, I would do injections.
Okay, I sent her for 6 weeks of NSAIDs and muscle relaxers. Pain completely went away, and she was still happy with me. She saw I was a nice doctor.
I would just see her every 6 months or so to make sure she doesn't.
Good idea. Keep the office flowing. Good idea. Yeah, I like that. I like that. All right, good. All right, 9 years later, she comes back. Now the sciatica's horrible. All right, Ocean, what do you see now?
There's a progression of that L4, L5 listhesis to almost probably grade 2 now, depending on place. You can see it there.
Is there lordosis at 4-5?
No, it looks more kyphotic there, if anything.
What's the disc? Is it a big disc at 4-5 or a small disc?
No, it's a small disc.
Decreased height? Yeah. And flex extension, do they help you?
Yeah, you can see that there's a little bit of instability there. She becomes more kyphotic on the flexion. It reduces a little bit there on extension.
Okay.
And she's got a huge,
MRI?
yeah, so you can see there. Maybe some of that disc has become calcified, I'm not sure, but it's bulging out quite a bit.
How about
You can see the listhesis, and it's not as reduced as we've seen before when she's been in supine position.
Interesting, right? How about the foramen, the left foramen, the 4-5?
Looks pretty tight. There's some disc material in there as well.
Describe this foramen.
It's nice and open. You can see the kind of fat all around.
Yeah, you can see the root.
Fried egg, nice.
How about this one? Oh, I like fried egg. And this one?
Not quite. It's not as bright. You see the disc right there.
Uh-huh.
It's I don't know, poached.
It's broken.
And what is the bright around the nerve there that you're in the normal frame? What's that?
I thought it was
that bright.
I thought that would be more fat.
Yeah.
Yeah.
Perfect.
Okay, good job. And just another view, the foramen is very stenotic. And we have the fluid still in the facet.
Yep.
And then what about 5-1?
So 5-1, it's kind of similar to that MRI we saw before, maybe a little bit more progression on that left-sided foraminal stenosis.
What's this?
Especially in that osteophyte.
She has no right sciatica.
Yeah, but that's progressed too. It's a little bit more compressive there. That osteophyte or facet hypertrophy.
4-5?
Oh, there's very tight here. There's some central canal stenosis.
Can you see any CSF?
No.
Okay. Can you see any individual nerve roots?
I think so.
Don't lie, Ocean.
I couldn't tell if that's.
Don't lie.
No.
Don't lie. Okay, just 2 millimeters higher.
It's a little bit more open there. You can see some nerve roots.
What is this?
Disc.
Mhm.
Stuff like this.
The facets, are the facets subluxated, destroyed, normal?
They don't look normal to me. It's hard to even kind of make out the joint itself.
So this point, where should it be? Probably all the way up here, right?
Something back, more back.
Okay.
So it is subluxated then?
It should look like that.
Correct.
It's at 3-4. Okay, now what do we do? Who wants to take a stab at it? Do we keep doing same thing, Grant, because she likes you?
It's been nice seeing her every 6 months, but I would say no. I think.
Probably NSAIDs are probably not going to work in this patient, would you
No.
say? I mean, I think it's a waste of time.
So 3-4 was pretty clear.
3-4 is normal.
I would probably do. I think your goals are here to stabilize the slip, try to reduce it, and then restore some more doses. So maybe like a L4, L5, S1 push-tron fusion with like a 4-5 T lift to try to bring up your lordosis a little bit.
All right, good. Mesfin, do you have anything to add to that? So he said a 4-5 T-lift, fusion, revision, decompression. Is that anything else that you say?
I said
Probably do a 5-1 T lift as well.
5-1.
You know, the thing that worries me with this lady, again, is just all with soft tissue. Looks like she might have lost a little weight in the 9 years, 9 intervening years, but still going to be a morbidly obese patient. So I might try to treat this patient for symptoms that are still unilateral through a 2-incision approach, where I would perk the unaffected side, perk taking screws, 4-5, and that's 1, and then you open on the affected side.
Okay. So, so my thoughts were 4-5 was by far the big problem. So I did everything you guys said: revision, decompression, instrument fusion. And I think I usually don't use interbody devices, but I think I think you have to use an interbody device in this case because you want to restore the height and increase the fusion probability. And then at 5-1, I chose not to fuse it, but that L5S1 lateral recess stenosis really bothered me, and I think it's high probability it's going to become symptomatic in the near future. I know it's a little bit prophylactic, but I felt I should decompress it because then I'll feel very stupid if she gets the problem later on. It's a small thing. So I did a decompress 5-1, revision decompression 4-5. So just want to go over the steps. How did the disc height? How did I get this? I'm a really good surgeon. I got this to almost reduce and disc height. How did I do that? I'm really good. How did I do that, Ocean?
That could just be her positioning supine.
Yeah, and positioning, not supine, but prone.
Maybe. Oh yeah, sorry, prone.
Yeah.
Then maybe flexing the table a little bit.
I didn't do anything. I mean, the table itself, the Jackson table, has a tendency to extend people, and most people, elderly people, don't walk straight. Other than, I mean, Carlton's the only person, adult, who walks straight. Everybody else is kyphotic. Me and Paul is doing. We're all a little kyphotic. So because everybody's kyphotic, when you make them straight, that's actually relative extension.
What's that bright spot in the intermediate roll space?
Yeah, what's that bright spot? Ocean, Dr. Duval.
Is that? I mean,
If you saw, how about if you saw on an X-ray, you saw a black spot,
last time be air. Is it air? Did you already do the dissection?
Yeah.
like a vacuum? And why is there a vacuum there?
Because there's, well, yeah, you lose disc and then there's instability. So then.
So when you go in the front in these cases, there's like a hole there when it's reduced. It's like just a vacuum. Okay, so I didn't. So it just reduced by itself. But also, general anesthesia relaxes all the musculature, allows it to slide. So this is just proving my level, starting point. I changed it a little bit. Next one, put that. Next one, change it.
How do you determine how much of that listhesis you want to reduce? Because she's been like this now. This has been a chronic process. It took 9 years to get to this point. She compensates for that. And so then if you brought her back to...
That's a Paul Dorian question because he's the most experienced. How much do you reduce, Paul?
I reduce as much as it'll give me, and on a patient like this, just on a table, you've gotten her back to almost complete reduction, and I think just by fixing your L5 screw and and putting your 4 or 5, bringing it to the rod, you should get 100% reduction on her.
The other thing I do in every case is I take the burr and I drill out the whole facet. I take all the cartilage out of the facet, all of it, all the way down, and that I think loosens it up, slides a little more, makes it easier.
Or you do that, or you do a Ponte, you just take the facet off completely.
It's certainly similar.
What's the board answer? The in-training exam answer, in terms of reducing the listhesis? Someone comes in, sees you with grade 2, grade 3 listhesis. What's the in-training answer? Because there's a difference between the clinical, what we do in practice, and boards. That's a hint.
What are the risks of reduction? 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 Everything has a risk. You can pull on the L4 nerve root in this case. It's not that big of a, what else? There are many risks. You can pull the screw out. Or the screw can pull out post-op. I've had all these complications.
If you put too much strain on it, you're at risk for loosening afterwards, right?
Yeah. Deformities have a tendency to recur. That's why I think you need an interbody. I think it decreases the probability of a pull-out post-op. Also, operative time, futzing, time on the muscle, death of the muscle while you're doing a surgery. I mean, all you're focused on the reduction, but in reality, the case gets longer, increases your infection risks. You get tired. Maybe you get a CSF leak because you're tired. All these are risks. Okay, so then the AP screws are medial. The trial, you can see there's a big disc space now, which is nice. And then the interbody, which is PEEK, has bone graft in it.
You got lordotic interbody?
8 degrees. It's an 8-degree lordotic interbody. And it's not straight in. You see how it's kind of crosses the midline, so it's across. Hopefully, it keeps the disc space up. And here's the post-op. So hopefully her spine is sort of normal now and will not continue to deteriorate. Hopefully the screws won't pull out. Hopefully this interbody won't move. Hopefully it will fuse. Hopefully 5-1 will not deteriorate further.
Let me just say that, if you look at the current concepts in where we're going with spinal surgery, there's a tremendous focus on sagittal balance. And what percentage of your lordosis is from L4 to S1, would you say, of the lumbar spine?
Majority of it.
What percentage?
46. Yeah, I would say like 70%.
60%.
Okay.
Okay. So I think that if you truly want to look at what is the optimum treatment for this patient, I think, and I'm saying would be not talking practical, it would have been to restore the L4 to S1 sagittal balance completely, which would have been probably A-lifts at 4-5 and 5-1, because you really cannot, especially 5-1. If you would have included 5-1, and I probably would have included 5-1, I never with an expandable cage would have gotten that lordotic. But, I do think that when you're doing this and you're trying to get the lordosis at 4-5, I would have tried to do a 15-degree cage to really maximize that lordosis to compensate for the 5-1 hypolordosis. Because I've seen plenty of patients over my years that they then start to march up their spine because they then try to compensate at 3-4. They hyperlordose that segment and they wind up with stenosis 5 years, 10 years down the line. So the way people are thinking now, and now this goes on to patients who then wind up having fusions up to the thoracic spine, and you really want to get that 4 to S1, maximize that lordosis. And and this patient was supple, so you were able to get really good lordosis there. I'm just saying she'll do fine, but I think there's a potential for her to
maybe not
break down.
Yeah, she may break down.
I mean, the other good thing about her is, I think all spines aren't created equal, and her spine is not one of these patients who has multi-level degeneration or genomic spine disease. She looks like she had perfect discs above the segment. So genetically, she has a better spine. So she's less likely to break down.
3-4 looks good so far.
Right. I'm saying from there up, that's a pretty good looking spine for someone her age. I mean, we see people that, who have every levels of degeneration. They're probably more prone to develop this progressive domino effect than a person who's got a really good spine, except for one or two segments that are bad. And that I think genetically they can probably do better. But just to say that the goal, this is the way the thinking is, that you really want to be aggressive from 4 to S1 to get as much lordosis as you can, so you don't have to compensate above, which then creates that domino effect with the need for additional surgery down the road as people get older.
I mean, agreed, but there's a cost to everything that you do. So
I'm saying in a perfect world.
In a perfect
we don't
world.
live in a perfect world.
Like
but,
a 150-pound,
Yeah.
like 5'6" person would be a lot
Absolutely.
easier to do an A-lift.
Absolutely.
This
Absolutely.
one I think would. I mean, I wouldn't do it.
I'm not saying I would either. I would have. I mean,
Certain body
I'm
habits
just-
you can't do an A-lift.
I'm just absolutely. I'm just saying that. I'm giving you
Definitely.
the way things are going with spine as far as the concepts. All right.
Yeah.
And now hopefully we'll get better techniques for improving posterior lordosis. Lordosis from a posterior approach. The expandable cages have really helped. And now we have 15-degree expandable cages that really give us some good lordosis if you have a mobile spine. But the 5-1 is very difficult when you're, in my experience, to get any real good lordosis there when you have that collapsed parallel disc at 5-1. Even if you do fascectomy and you try to work it, it doesn't seem to open up.
Also, 5'1" is the highest non-union risk.
And
So-
one of the reasons why the 4-5 improves is because you think about it, you slip forwards. When you pull it back, you're taking the tension off of those ligaments that are being stretched. That's why you can get it usually the height restored at that 4 or 5 segment. It's because I've had patients who slip to a grade 2 and they're bone on bone, and you put them on the table and you're surprised at how much they'll come up because it releases that tension on the ligaments when they have the listhesis. If they don't, like 5-1, it's much harder to do that.
I do it similar to Mesfin. I use the percutaneous instrumentation, but I just under my eyes I get the starting point, and then everything is percutaneous. That takes the stress off the screws. And there's other technique. I don't know if this is stupid, but if you understand this. But this thing I've learned from mistakes is once I have my wire and I put my screw in, I just move the wire a little bit, and if there's any kind of tension or scraping, I'm not on. Do you understand that? So you have the wire in. If it's off a little bit, you can't move the wire. So if you just keep testing it, you're going straight down the wire. If you don't go straight down the wire bends. It can get stuck. Also, the screw's not going where you want it to go. So as you're putting in these serious screws, and this is any screw like tibia, femur, you make sure you're dead on. Usually in the extremities it's easy, but in the spines, a lot of soft tissue, it's not as easy. And just to make sure you're dead on, I just barely move it as I push it down. I go 5 millimeters, I check it, 5 millimeters, I check it, and then it goes, and then I can just pull the wire straight out. If you're off, you can't pull the wire out. So it's easy to get off.
The other quick concept is what he did was this a load bearing or load sharing construct? What he did. Major concept in orthopedics, right?
Right.
Load bearing versus load sharing. Was that a load bearing or a load sharing construct? Is posterior instrumentation.
Posterior is load sharing.
Right, because you have anterior support.
Correct.
So that's a very important, again, in the spine as well. If you're reducing something, you want to have a load sharing posterior construct, or you have a greater chance of your screws pulling out, the bone breaking, and in the past, when we first started, we didn't have interbodies. We were doing all these just posterior with instrumentation, and some would reduce, some would kind of slip back to the original thing.
Interbodies are like 98, 99.
Yeah.
What were you putting in the disc space? Just bone graft?
Nothing. We would do all posterior lateral without any interbodies initially when I first started
A-lifts,
practicing.
we do A-lifts, but nothing from a posterior. But yeah, they came out in 98, 99. What else I want to say in this case? Messer, do you have any other comments?
No, I think that's a good outcome. The only thing, again, is just there'll be some debate as to whether it would have been worth incorporating the S1 posteriorly. I would not consider an A-lift on this.
Yeah, so
patient.
this was a difficult case. I mean, I don't want to make excuses, but her body habitus was very large.
Yeah.
So, and as it was, I'm not a slow surgeon. I'm not the fastest, but it took me 4.5 hours. And I think it would have taken me another hour to fuse 5-1, maybe another hour and a half for interbody. I mean, after 6 hours, I'm no good. I can keep going, but I'm not as good as I was hour 1 through 0 through 4. So this is everything you have to, I take into consideration anyway. I'd rather stage it. I'd rather take her back for the 5-1 decompression fusion when Grant's a senior chief. That way he can help me. He's a young guy. He's really strong.
10 years from now.
Yeah, he's a really young, strong guy.
10-year program.
Okay. All right, any other questions?
No, that was awesome. Thank you.
Quickly, so
Yeah.
Postop. So she's upstairs right now. The surgery was done yesterday. Yeah, and her left-sided sciatica is much better. So yeah, it's just incisional pain. She's doing well.
Oh, good. I thought you were going to give me bad news. I was like, be quiet.
Yeah.
Oh, thank you. Thank you.
Yeah, so take a look at her
Dr.
Postop
Historian.
X-ray.
I know.